Now, we have Dr. MERINE Paul, who's our next speaker, is a very prominent ophthalmologist from Kerala, who's a consultant ophthalmologist at Vijay Sri Hospital, Trichy, and she is going to share her pearl of wisdom. On to you, Dr. MERINE Paul.
Good afternoon, everyone, and thank you, Dr. Chitra, for giving me this opportunity. So let me share my video for you all. So basically, what I wanted to tell in this is that many times we start surgery in situations which are not ideal, or we have to do surgery in situations which are not ideal. So what happens is that almost 90% of our surgeons across India have a phaco machine and a microscope. And the management tells them you manage with that. So please listen to this.
Female patient who posted as the last case on a long OT list. Supply issues due to COVID caused a shortage of iris hooks that day, but I was not expecting trouble. Rexis proceeded smoothly, but the hydrodissection saw the pupil snapping down. So I used viscoat to get a little more working space, but the moment I tried to dial or rotate the nucleus, and when I put the probe in, I realized I was not just dealing with intraoperative meiosis, but also IFIS. So at this point, now there was no going back, and I had to proceed with whatever I had at hand. So with utmost caution, I tried to do a central chop, but the nucleus was extremely soft, and I had to repeatedly use viscoat to keep the iris back and also to get some amount of space in the pupillary area. So finally, after repeated introduction of high molecular weight viscoelastic and keeping the probe extremely central, not moving it at all, I was able to get in the first crack there, and then the subsequent cracks became much more easier. But at every point, I made sure that the probe does not engage with the iris tissue, because even if once the probe touched the iris tissue, the whole game would be lost, as the iris would become extremely floppy and continue to flow into the probe, and it would have been extremely difficult to continue with the surgery. This is, of course, a fast-forwarded video, and the actual pace of the surgery was glacial. Very, very slow movements and keeping the probe absolutely steadily at the center. The nucleus was fully managed, complication-free. Again, high molecular weight viscoelastic was introduced into the chamber, and coaxial irrigation aspiration was done, and the cortical material was removed in toto, including the subincisional cortex. And after carefully inspecting the bag, we injected the IOL into the bag and rotated it into the bag. And once the IOL was in the bag, the same Fuglen hoop was used to inspect all parts of the bag 360 degrees to ensure that there was no remnant nuclear or cortical material. And at the end of the surgery, there was a slight iris shaping, but the cornea was clear and the surgery went well. Thank you.
Thanks, Dr. MERINE. That was a
just a minute, please, ma'am. So what I wanted to say here was that this was a situation where I did not have an iris hook. The only thing that was left in the OT that day was high molecular weight viscoelastic. So what should be my takeaway points here are that: one, if it is female, don't think IFIS will not happen. Two, always stain the nucleus, use iris hooks whenever possible. And now the phenocaine is there, even that would have helped tremendously in this case. Thank you. Comments, please.
Yes, thanks a lot, Dr. Marine. That was a daring surgery, but I think you got away lucky because it's one of those small rigid pupil, not a floppy iris, because I would have a very low threshold of using a iris hook, and I'm sure you would have used too. As
no, it was not there, ma'am. See, there are conditions where there's a long list, and they said at the end of the day, oh, it is all over. We don't have any more iris hooks.
Yeah.
So this was the idea there.
So in a normal scenario, yes, iris hooks should have been used in this particular case. And I would also wonder about going through the side port to deposit the iris. Because the iris did not have the floppiness, you could go in through the main port, because when you start doing that, then the iris starts coming out a lot more. And phenocaine, I think, does have a role. It tightens the dilator pupillae muscle. So besides a pre-planned using atropine ointment, which again prevents pupillary dilatation, this keeps the tone of the muscle and does have its role. So cannot, as you said, phenocaine could have been tried and iris hooks. But I think it was a very well done surgery. The way you kept your phacoprobe right at the center, and I'm sure your stable parameters would have also been there, which ensured that there was no turbulence in the eye. Dr. Madhukar, would you want to add something? Dr. Madhukar, are you there? It's not there.
Oh, yes. No, I'm there. I'm there.
Yeah. Tell me, Dr. Madhukar.
No. Basically, she has managed it very well. I think all of us face these situations day in and day out. So IFIS can occur anytime, and iris hooks would have helped. That's the only thing. Nothing more to add.
Nothing more to add. Yes, Dr. Ramurthy?
I think very well done. I mean, very, very nicely managed. What we have to differentiate is between small pupil phacoemulsification and small rhexis phacoemulsification. The greatest difficulty we have with small pupils is the size of the rhexis that we are able to create. And as we saw in Dr. Merine's case, initially the pupil was quite all right. It was almost 4.5 millimeters. I think most of us would not have used iris hooks in that situation, even if it was available. So obviously she did the right thing and she got a rhexis of the right size. I think half the battle was won because she had the rhexis was of the right size, and subsequently the pupil came down, and surgeon of her quality and her experience obviously managed quite well using low parameters. As I emphasized in the last case, why the entire nucleus emulsification removal looks a little shabby and cumbersome in some cases is because we don't break the backbone of the nucleus. In this case, again, I'd emphasize that even though the pupil had come down, I just go ahead with downslope sculpting. I mean, I do chopping routinely in my cases, but whenever I chop doesn't work for me, I go ahead and just convert it into a stop and chop technique and thin out the posterior plate, going either with the 2 Sinskey hooks or with the 1 Sinskey hook and 1 phacoprobe, and split the nucleus into 2 halves. Once that is done, even if the nucleus is even if the pupil is reasonably small, you can easily get that out. And she did say about high molecular weight viscoelastic, but I think she was mentioning viscode. In these situations, sometimes using Helon to get a really viscomydriasis would be a good idea. And the other point which has been mentioned in passing is that when you have repeated iris prolapse, please remember it's not the prolapse of the iris which damages the iris, but it is the reposition of the iris which damages it. So in these cases, going through the side port and gently snapping it down would be a good idea. And if you put a blob of Helon on top of that, then it's likely to stay. Of course, there is also a tendency for Helon to come out more quickly, but then you might be able to reposit the iris for you to allow you to get the phacoprobe inside and do the rest of the phacoemulsification. Well managed. Obviously, sitting on a sofa, you can comment a lot of things, but what you do on the surgical table is what matters, and I think that was well done.
Thanks a lot, Dr. Merine. That was a wonderful